thank you. Good, thank you everyone. So thank you for staying awake till now. I'm talking about a software which is open source. It is easy to get. It is on the internet. There are a lot of videos on YouTube how to use this software. I'm going to talk about how to analyze tower on this. This is a small module. There are multiple modules. If I click here, there is a module written here. Can you see that? And if I click here, there are multiple modules here. We can do a lot of things here. I do 3D printing using this software. There's a cardiac module where you can actually put devices here. You can put ASD, VSD device, you can plan a baffle, you can put other cardiac devices, you can put a stent here. You can simulate a tower implant here. You can do mitra clip simulation also here. So this is a very powerful software developed by NIH for cancer care patients. It includes cardiac modules also. What we have done is we have created a tower module in it. So essentially, when we analyze tower, we look at the lowermost part of the annulus as Megha has just told us. Now, different softwares can do it. There is Horos in Mac, there is 3D Slicer, some people use some other softwares also. The idea is to go and find the lowermost part of an annulus. That's it. If you find all the three annuluses lowermost point, that is the plane that we have to define, and based on that all our these calculations are there. The annulus calculations, the LVOT calculations, 4 mm below that, the sinotubular junction calculations, the coronary heights, based on that point. Now, how to automate it, that was the question, and one thing that Freeman-Shaw gives, and it gives royally, is an S-curve. The S-curve defines the movement of aortic annulus, or maybe the movement of the camera around the aortic annulus, such that we get to see the optimal views around the aortic annulus. Now, there is a concept of cusp overlap views. The cusp overlap views are not only important for coronary alignment, they are also important for placing the valve optimally. Now, in a balloon expandable valve, it is not that important because the balloon expandable valve itself is very small. By the time you are inflating, it's over. You have no control over it. Versus a self-expanding valve is a very long valve, and it is like going with something inside a bottle, and if your orientation is not perpendicular to the origin of the water, you may land up in a canted manner. So how to orient yourself perpendicular to the annulus is described very well using this S curves. So let us go through the steps of it. First of all, as Megha has done there, we will centralize the annulus. Now you should realize that this plane, the most left one, where my marker is, it's the transverse plane. The central one is the coronal plane, and the rightward one is the sagittal plane. We centralize the annulus on the sagittal and coronal plane. I am just manually doing that, and then we go to right cusp first. We centralize it, and we are coming down. So there are various ways to come down. The easiest is you just come down here with the red marker. There is still some annulus seen there. I am going down some bit more. I'll accept this, and see, this is my first point. I'll put R mark here. Now, as Megha had shown the other way of going and finding the lowermost annulus step by step, we can do that also, or we can do another technique. I will rotate this green mark and go towards the non-coronary cusp, and see the green is here, the green bar is here, see my marker, and I'll just rotate this red to go to the lowermost part of this, and as soon as, so I have lost it, so this is the plane of non-coronary cusp. I'll click, I'll put the non-coronary cusp here. Okay, now I'll come like this, the yellow in the center. This will be the point of the left coronary cusp. The yellow is here. I'll go up, and I'll go down again to the, I've lost it, so this is the plane. So I again put the L mark. So I have put the 3 L marks. Now I'll click on the right and non being overlapped. So you can see that there is an angle here written, which is LAO caudal, which is a right and non-cusps are overlapped, means the left cusp is isolated. Then I'll click on right left. There is areocranial here and left non-overlap. This is ariocaudal here. So these are the angulations which correspond to the traditional cusp overlap views which we are used to seeing. And then I will click on this generate S curve and you see the S curve here. And then this S curve is, the standard aortic S curve, it goes from the, these are the 4 quadrants of the S curve. This quadrant is aleocranial, so the horizontal line is divided into aleo part and the areo part. The vertical line is divided into cranial part and the caudal part. So this is the aleocranial part, this is the areocranial part, this is the ariocaudal part, this is the aleocaudal part. So S curve of any object, any part of our human body or any part of our heart will go through only 3 quadrants. The 4th empty quadrant corresponds to the en-face view of that. Suppose it's aorta, the en-face view of the aorta will be corresponding to this 4th quadrant, which is in the areocranial part. So now, if you look at this S curve, it is, if you see, it is almost like giving an angle of around, if you create a tangent, it will be around 35 degrees to 40 degrees. So that is what is the alpha angle that we see when we calculate the alpha angle. That will be the alpha angle. So if it is a vertical S curve, the aorta is horizontal. The annulus is vertical, the aorta is horizontal. If the S curve is like this, the annulus is this horizontal and the aorta is vertical. That is what we like.
So in a horizontal aorta, the en-face view will be deep areo without any cranial or caudal angulation.
This is why I have made this software. I don't know. Maybe you will be finding this.
No, forget the software. Let's use imagination.
That's why. Why are you able to imagine it? Because you are seeing the S curve. Yeah. Without seeing the S curve, how do you imagine that?
But S curve came out from geometry, 3-dimensional geometry.
S curve is based on trigonometric formulations. I accept it completely. But
if you remember when I was in first year, to show the en-face view of the aortic valve, metallic aortic valve, we used to take that deep areocranial view and we used to see the en-face view and then just perpendicular in the areocaudal.
So basically what I believe is that as we change the areo and the caudal, the S curve changes. It does not just only depend on the areo views, it depends on the caudal views also. So how much caudally we are moving, that also determines it. I am learning it. At this point I do not know it. I am still studying this. But that is what the whole opinion is. That is what I believe in.
Arvind, what is the practical application of this S curve? Could you tell that?
So the most practical application of this S curve is when we are deploying a self-expanding ball. In a self-expanding ball, when we start deploying it, the history is that they started deploying it in the aleocranial view or aleo view, the standard view, which we used to take our angiograms in, which we used to believe that we see the whole LVUT properly and we used to go through it. But they started finding that the valve used to deploy much deeper and patients had a lot of CHVs. So to take care of that, they started studying the S curves, where it would be possible to find the exact depth of the implantation. And they found that the valve annulus is parallel and the LVUT is most elongated, or you can say not foreshortened at all in ariocaudal views. Incidentally, this ariocaudal view is also cusp overlap view for non-coronary cusp is isolated in that. And one more thing is that if we draw, if you see at the aorta, every catheter, because of the weight of the catheter, it will come from the outer curve. And the outer curve eventually lands all the devices to land on the non and right coronary commissure. Commissure comprising of the non-cusp and the right cusp. So the end cusp, the end commissure. So just below that there is a perimembranous septum. So when we are deeping dive into it, we are actually hurting the perimembranous septum and the AV node. So they wanted to take care of that, and So this is the nature's plan, that somehow the same view has 3 or 4 wonderful things. First, it is the narrowest diameter. It gives the narrowest diameter of the aorta. It is having the most elongated LVOT. It has a part which gives you the original, the implantation starting depth from where you can start. Even for balloon expandable valves, we can go to RA caudal view and start from there. In my institute, we had started doing that. We did not use implanters view. We used to go to RA caudal and implant from there only, because we are actually getting the depth. We want the depth, and it is the best way to get the depth.
And even in RL fusion of a bicuspid aortic valve, when you are doing a BAV, you would be able to cross better if you go to this view.
See, we can cross in different views. For crossing, I'll tell you one principle.
Crossing means
For crossing, I'll tell you one principle. When you are looking at a valve, this software can give 3D. I do not have a time, but when you create a 3D model of the aortic valve, you understand that the orifice of the valve is in the center. So you try to go to the center of the valve for crossing the valve.
Arvind, still we don't know what's the practical application in this S curve, because correct me if I'm wrong.
Okay.
Correct
Can
me
I
if I'm
use
wrong.
this?
No,
Can I
let me
use this?
see. I'm learning from you.
Yeah.
Correct me if I'm wrong. Okay. So this point, the RA caudal point,
Yes.
represents the left cusp, and that represents the non. And when you go right up, the R moves along with that. Is it like that?
I'll tell you.
So left and right will coact in this view here, in this part of the S curve.
So this is areocranial. So
Can you draw and show?
Yes. Okay.
Okay, project
so
kar do zara.
can this be here? Okay.
Show it.
So this is.
Pen change kar.
Okay. So this is the S curve.
Yes.
Okay. So this S curve has certain points where you will get the 3 points in line, and certain points where you will get 2 points like this or 2 points like this. Okay.
Right.
So we know by pattern recognition now that somewhere here the non will be like this, and the right and the left cusps will be overlapping like this, and somewhere here the left will be like this, and the non and the right will be coming like this, and somewhere here, very deep here or very deep here, around 90 degree and very cranial or very caudal, you will have right like this, and the non and the left will be like this, because it is very cranial and very lateral also.
1 minute.
So this is the first information.
Can you draw this again?
Yeah.
Just draw the S curve.
Okay.
Draw the S curve. Fine. So here you will have the right, somewhere here you will have the right and left overlap,
Yeah.
and the non will be separate, right?
Yes.
Somewhere here you will have the right and non overlap, and the left will be separate,
Yes.
right?
Yes.
Somewhere here in between you will have the
Non-right left.
R, L and N all three separate, right?
NR.
NRL, sorry. N, R, L, all three separate.
Yes,
Barabar?
yes,
Now
yes.
when you get the device, this is the S curve for the cusp. When you get the device
Yes.
S curve, it will be somewhere cutting like this, and where both cut each other, that will be the ideal
So
point.
the
right?
device curve is something like this. The device. So I have drawn the device curve.
They will cut at one point.
Okay. Can we move to the next page? Somewhere? Okay. Can we move to the next page? Okay. So the S curve of the aorta is something like this, and we change the color maybe, and the S curve of the device is something like this. They actually are in the areocaudal only. So when Nicola Piazza, the one who described these S curves, he said the device is coming in the different plane and the aorta is in a different plane. So it's something like this. The plane of the aorta is like this, but the device is like this. Device is not like this. It's coming like this. So when it is going to open, we don't know that this is the right way to look at it. So he created S curves for the device also, and he found where they are intersecting. And the plane at which they were intersecting, they were looking the most, it is an illusion. Whatever we are looking on fluoroscopy is an illusion. The beauty is that we work through illusion very well. So he found that when we are looking at this point where they cut each other, they are most parallel. It is not like this, it is somewhere like this. So he said, use a double S curve. Create an S curve of the aorta and create an S curve of the device also. But then people were not really willing to do this double S curve thing. They really defined this cusp overlap view, and incidentally, the view that they chose was ariocaudal only.
There are operators who choose the other overlap. So there are operators like, there is the operator from UK, Mr. Ganesh Manoharan. So he uses the R and L overlap and then deploys the wall, or the left getting isolated.
So in Milan, in San Raffaele, we used both the views. We started in ariocaudal. So in ariocaudal, so if this is the annulus of the aorta, this is the narrow diameter, this is the long diameter. The narrow diameter corresponds to our plaxma. That is ariocaudal. That is pattern recognition. Just remember this. You don't have to remember, you don't have to think long. Just remember this. Ariocaudal is plax view, is the shortest diameter. When we used to do BAV, we used to see ariocaudal, calculate the annulus size and take 90% of that for BAV. We were very lucky. We were really very lucky.
So ariocaudal is the view because in that view the LVOT opens up completely and therefore you get the right depth. So that's very important for all.
In an ariocaudal view, basically, if you look at this, the aorta is like this, the mitral valve is like this, and LVOT is like this, but the LV is like this. It's not a good view to look at the LV. The LV does not elongate. When the catheter is being pushed, you don't get an idea of where the catheter is going. It's really a shallow view for the LV. But the LVOT is 4 length.
So vertical
you get a better
structures
view of
elongate
this part.
with caudal projection. It's the same.
What?
Vertical structures tend to elongate more with caudal projection. That's why the LVOT elongates in the caudal. And the RO is principally because you want to overlap the...
See, I don't know how your heart is oriented in your body.
No, I'm talking about...
I don't
you want to come here?
The concept you're talking about is right, but I don't know how the heart is oriented in your
So
body.
let's not confuse. So ariocaudal view is a good view to open up the foreshortened LVOT, and that's the view where Arvind beautifully showed that Niccolo Piazza has a beautiful paper if you want to go and read. And S-curves, as Arvind told, can be made for everything. Even for paravalvular leaks, if you want to see a paravalvular leak, how it's going on, you can actually make an S-curve for that. You can make for the like Akshay, if you have a stuck valve in your this thing, you can actually see where it's where it is aligned and where it's not. So basically S-curve is that, and you get a lot of information about that, but it's more of theory. For practical application, it's the ariocaudal view for us for opening out the foreshortened LVOT. Like Dr. Manoharan, he propagates an aleocranial because he wants to see the left coronary as how far it is, and he also wants to see the depth at the left side. In especially self-expanding valves, this is important.
So for us, we started at ariocaudal. We used to deploy at ariocaudal. Halfway during deployment, we would change to aleocranial. So in an ariocaudal, the valve has opened something like this. It opens like this. But when we go to aleocranial, it looks like this. Now this is the annulus. We can take an angio. We'll see the annulus is like this. The valve may open like this, or the valve may open like this, or the valve may open like this. If it is opening like this, we have to resheath it. If it is opening like this, and we continue opening it, it may turn like this. So we remove the wire. We keep the wire up to the nose cone. It is third law of motion. If you keep the wire inside the LV, the device will keep on tilting back. Because you are pushing like this, the device will keep on tilting back. So if the device is exactly the way you just pull the wire, keep it inside the nose cone and deploy the wire. Whereas up to 80%, see how it is, and then you can deploy further. Whereas if it is like this, annulus is like this and the valve is like this, you push and then deploy. While you are pushing and deploying, it will come like this. This is what we used to do, sir, using both the ariocaudal and aleocranial views to deploy self-expanding.
So I have an example. I'll ask you an example. You are deploying a self-expanding valve in the ariocaudal projection and you are happy with it. You go on to the aleocranial projection or plain aleo projection. You see that this side, the valve is a bit shallow. So in order to get the valve in a bit more on this side, because you don't want it to pop out, would you pull the wire?
My deployment point is ariocaudal. That is the point where the valve is actually hinged. Yeah. It starts deploying from there. It does not move from there. It moves from the other side.
No, I'm talking about the other side. The other side is not satisfactory.
In the other side, see, if this is the annulus, in the ariocaudal, I don't know how it is oriented. I just open it. In aleocranial, if it is like this, versus like this, versus like this. If it is this, I'll resheath it. If it is like this, I am happy actually, but I want to be cautious that it does not tilt out. So I pull out the wire and deploy the rest of the device. If it is like this, I push the wire. So it's like if you're pushing here, it comes like this. So suppose this is the annulus, this is the S curve of the annulus, we know that, and we create one more point. So we can create points here. This is markups, and this is the point list. And suppose this patient has a paravalvular leak somewhere here. Suppose this patient has a paravalvular leak somewhere here, F11. Now I'll go here. I'll enlarge this view. Okay, and I can rotate this. You can see that the F yeah, that's what I'm going to do. That's what I'm going to do. That's what I do. What I do is that I isolate the F. I make the F go in one direction, and I let the other three in other directions. So, and that angulation should be feasible. It should be from RAO 45 to LAO 45 and cranial 30 to caudal 30. Somewhere in that range, if I can isolate that F1 point from the three cuspal points, I'm good. That is my angulation. And this is coming out. Yeah. So
Dheeraj, aortic paravalvulars are easier to delineate. Medial mitral paravalvulars are really troublesome.
the same principle. The principle does not change.
Yeah, the principle doesn't change, but then to get an orientation sometimes becomes very difficult, the one which you are talking about. Secondly, if you're medial, crossing it also is an issue unless an agilis, you have an agilis which goes on to the medial side and you cross it. So these are two issues with mitral paravalvulars.
In the last 6 years of treating paravalvular leaks, what I have learned is that my learning has changed slowly a bit. In the beginning, I used to feel that medial paravalvular leaks, you take transapical access, either you take percutaneously or take the help of a surgeon, directly enter it, close it, come out, 5 minutes job. It's a very simple thing. If you use any other technique, it will be a hell of a job. Now I feel that with my second training with Professor Mesano, you can access a medial leak and close it within 15 minutes. The idea is where to puncture. The idea is coaxiality. You can cross any leak and then push the sheath inside the other side of the leak if you are coaxial to it. The problem happens, you can cross any leak. Basically, medial leak is not
Can you be coaxial in the medial side? How?
Yeah, so what Mesano does is that if this is the
Please
heart,
display the iPad.
if this is the heart and this is the septum, the medial leaks for those, he will be anterior mid part but a bit anterior. Normally he takes all the access, all the transeptal punctures here. That's his point. It is only for medial leaks that he will be there. The reason is he uses and he advocates to use medial curve agilis sheaths, which has a curve of around 16.8 mm. So it curves like this. So if the curve is like this and you are taking a posterior puncture, you will not be able to reach the medial leak. So you are near the leak, you just curve and you are there. You enter and that's the end of the procedure. Once you enter, you put a backup nerve wire, you put a safari wire anywhere, it is done.
That is the way we access the parahesian pathways on the left hand side. So you use a median curve. All this agilis was made for EP guys.
Yeah.
But
I started with the EP guys. Because agilis has made life very easy for this medial leaks. Otherwise, it was a big problem to cross the medial leaks. So we have had cases where it took hours together to cross the medial leaks.
Basically, crossing you can cross from the aortic end. You come from the aortic end and you look medially, you will be able to cross it. So that is you go to a 4-chamber view, go as cranial as pattern recognition. Go as cranial as possible. Go at least 0 to 10 degree to 15 degree LAO. And from that, look medially. So medially is where in the center of towards the spine. So you look medially with the catheter like a EMA catheter or a JR catheter or any catheter, and you just cross. It will cross. So from LV to LA is very easy to cross. You take any transeptal access, you snare it. You try to go from venous to arterial, there will be a problem. Your catheter will not move inside if the leak is not big. If the leak is big, everything will go. If the leak is small, there the whole problem arises. Many people for a small leak, they will go from the aorta itself, put a 5 French sheath into the LA and then just close from the LA to L, the other way around. So I have seen Shivkumar sir do that also.
So we've had a case recently where a TAVI was done in an old mitral prosthesis, and after that the patient developed the aortomitral curtain injury, and along with that there was a paravalvular leak which was caused. It was a traumatic iatrogenic leak, and there was a big problem to cross it, and also with the device it was caused a lot of problems for us. So medial leaks can sometimes be, and through that TAVI valve to cross,
they were always a problem with
retro
Shivkumar.
was a real problem.
Middle leaks were always a problem with Shivkumar sir. They were not sometimes, always. I used to believe, I have worked with him almost for like 10 leaks. And I used to believe that middle leaks should be done from, because in the end you used to invariably go to apical, do it in 5 minutes. The problem with apical percutaneous is that you have no access, no knowledge about what are the vessels apart from the heart itself. So okay, you can just puncture the heart, go inside, do the closure, take a 10-8 or 8-6 EDO, come out, close that apex. It will not leak from that. The other vessels, the vessels supplying the lungs, the vasculature, you can hurt that, and there can be a huge hematoma. So then the patient goes for surgery for that. So rather than that, you just ask a surgeon to open it. It's a 15 minutes job for them and 5 minutes from there for you. So
Next year you can show the mitral valve S-curve.
Yeah.
You can show. Thank you, Arvind. Thanks a lot. And thank you everyone for staying awake till 1 o'clock. I think it's one of its kind conference. Till 1 o'clock this is going on. Thank you very much.